everyone. And on behalf of eCancer, it's a pleasure to present a discussion today with my very good friend and colleague, Fred Saad. I'm Neal Shore. I'm the medical director of Carolina Urologic Research Center and the CMO for Genesis Care and Surgery and Urology. What a great pleasure to have Fred Saad with me today. Fred is a professor of urology and a leading expert in international national studies in advanced geo-oncology. Fred is at the University of Montreal. Fred, welcome. We have a lot to discuss today in a fairly short time. Really what our focus today is for our colleagues in urology, especially around the recent AUA 2021 conference, is genomic profiling. And the reason, the importance, the how-to, the when-to of testing, whether it's germline or somatic. Fred, I know you've done a tremendous amount of work in this field, and you're actually helping to establish guidelines in Canada. I know you're familiar with NCCN, AUA, ASTRO, ASCO. Can you just comment, what do our colleagues need to be thinking about in terms of both germline and somatic testing? And then I think we'll review some of the abstracts and presentations that happened at AUA 2021.
Yeah, so Neal, you and I have been around for a few years, and we've been saying that we need to personalize care for a long time. And we've been talking about, family history and genomic testing, and it was all very good academic medicine, but in reality, it really didn't change much, right? I mean, knowing that somebody had a mutation, had a BRCA mutation, that was great, stressed a lot of people, but we had nothing to be able to offer these patients. So I think now understanding the importance of testing, knowing who we have in our clinic, has become critically important, because it's not only academic to know that they have a mutation or harbor a gene that makes them more susceptible to having cancer, but also less likely to respond well to whatever we give them. Because now we have therapeutic options that really will make a difference in these patients. So the guidelines now strongly recommend that patients be tested if they're at risk of having these mutations, because it will make a difference in how we manage these patients when they become metastatic castration resistant.
Yeah, I fully agree with you. It's the old adage. It's not about if, it's when. When will you start to do this? And because there's now clinical utility, as you say, actionable information. In May of 2020, we saw the approval of two PARP inhibitors, olaparib and rucaparib, for MCRPC. There's a little bit of difference and nuanced differences in the gene alterations between the two drugs and the inclusion criteria, but they're now approved, in North America for the most part, and EMA has similarly approved the use of these PARP inhibitors. So maybe, Fred, just for a second, can you get a little more into your specifics? And people will oftentimes ask, okay, so who should get germline testing? I tend to think about it as who shouldn't, because it's really almost everyone.
Yeah, no, that's a great point. I mean, I think anybody with especially high risk prostate cancer should be tested. Now, with what would be ideal and what we're doing in a poor country like Canada, where resources are limited and where, and I'm saying this facetiously, but we have to justify when we do things. So, a patient who walks in with metastatic hormone sensitive disease, regardless of age, I think clearly that is a good time to be testing. The low-hanging fruit are the patients closest to needing the therapies that we have to offer. Right now, they're only approved for MCRPC after having failed at least a novel hormonal therapy or an ARAT, one of the new therapies. So that is where there's the most amount of urgency to know whether they harbor these mutations, because we have therapies, like you say, that make a big difference in patients' lives. But knowing it when they're metastatic hormone sensitive is also very important, because we know these patients will progress to metastatic CRPC early, and we're introducing these therapies in the metastatic hormone sensitive state in a lot of these patients. So I think there are a lot of areas. So obviously knowing something early is really important, because when they progress, we already have this valuable information. But right now, if you ask me who is the most urgent, are patients who are on NHTs and are starting to progress. The slightest sign of progression, PSA progression, we need to know this information, because the next line of therapy will clearly depend on the information we get.
Yeah, I fully agree with you. That's right. It's really the actionability is in MCRPC, post NHA or post NHA and a taxane. You've got options. Of course, testing earlier is helpful because, well, first, number one, I mean, there's been a democratization for germline testing. It's a lot less expensive than it was, years ago when it was in the thousands of dollars. It's now just a few $100s for these tests, and it's blood-based or saliva-based. And as you said earlier, somatic testing or tumor testing for DNA alterations, gene alterations, is really important in MCRPC. That's across NCCN, AUA, ASCO, ESMO, EAU, CUA. And that becomes important, right? Because 50% of patients who may be germline negative for a HRR mutation may have an HRR mutation in a somatic mutation, which can be obtained through either tissue or a blood-based test, or what we call liquid-based testing. So that's a great overview. Thanks so much for that, Fred. Maybe we should just kind of just highlight some of the interesting presentations that were done at AUA this year. They were starting to look at PARPs, drugs such as olaparib and rucaparib, now in combination, and that's a pretty exciting area. And then there are a lot of other PARP inhibitors that are going to be entering the field. Maybe you'd like to comment on some of the work that you've done. In particular, I enjoyed your presentation on TALAPRO-1, and maybe you'd like to just comment about that there are other PARP inhibitors entering the field.
Yeah, so there, as you say, this is an exploding area of research. So there are several PARP inhibitors, talazoparib, rucaparib, olaparib, which is the most advanced because they were one of the first to be starting, and niraparib. So many PARP inhibitors, slight differences, but overall very effective. And what's, obviously for urologists that might be less familiar with PARP inhibitors, who are just getting into this field, whereas medical oncology have been using this for breast and ovarian cancer, and they're used to managing these adverse events that can occur. They are quite manageable. And what we presented in TALAPRO-1 was really the quality of life aspects that these drugs do have, risks of adverse events or side effects. But overall, when we use them appropriately, the quality of life seems to be improving in patients that are treated. And we've seen this repeatedly, whether it was olaparib, talazoparib, niraparib. So this is very encouraging that when we treat these patients appropriately, we don't diminish their quality of life. We actually improve their quality of life, as well as delaying progression. And at least one phase 3 study showed a clear advantage in overall survival. So clearly these patients don't do as well with what we give them as conventional therapy, but will benefit from a PARP inhibitor when they have these mutations.
Yeah, exactly. And here we've had the enjoyment to give oral novel hormonal agents, as you say, the androgen receptor axis drugs, ABI, ENZA, APA, DARO, and now we have an additional class of oral agents that are effective. But again, to your point, right now, if we do the testing correctly, it really amplifies this notion of precision-based medicine. And if you're not testing, you wouldn't have an opportunity to say, oh, I have somebody who's BRCA2 or BRCA1 or arguably some of the less common HRR mutations. And now the patient could really potentially add to their therapeutic choices of a PARP inhibitor. And I also appreciate that you said that these PARP inhibitors have been around for our medical oncology colleagues for quite some time in breast, ovarian, pancreatic cancer, and now prostate cancer. Fred, can you talk about, the management? Some of our colleagues will probably say, well, what do I need to be thinking about in terms of safety and toxicity?
Yeah, so overall, most patients will tolerate the drugs very well, and we won't have to really modify dose or any other aspects. But there are some patients that will develop anemia, will develop fatigue, and these are usually quite simple to manage if we've got the infrastructure to transfuse and then have the reflex of not stopping drug but reducing dose, because some patients respond very well at lower doses. But we should always start with full dose and then decide on dose modification to address these adverse events. But really, life-threatening adverse events are rare. The grade 3, 4 adverse events that are difficult to manage are rare. This is not chemotherapy. These are things that are in the realm of urologists who have already the clinical mass of patients and the interest to manage these patients. But your point of we're going to combination therapies and we're going also in earlier settings in patients that harbor these mutations. So the field is really growing, and this is good news for us, but especially for our patients.
Yeah, I agree. In my experience, yeah, the label, just check a CBC monthly, kind of like we've been doing with a drug such as radium-223. Not a big deal to check hemoglobin and hematocrit monthly. You can see some myelosuppression. If you see it, it's usually early on in the course of the disease. There's a little bit of, there is some grade 1, grade 2 GI, but very manageable. And as you say now, it's really exciting to think about combining. So were there any particular abstracts or combinations right now that are of interest to you, Fred? I know there's a big phase 3 that's pending, combining olaparib with abiraterone. There
Mhm.
certainly are a host of other trials now combining PARP inhibitors with a checkpoint inhibitor such as pembrolizumab, combining it with different PARPs with enzalutamide, combining PARPs with radium. It's an exciting opportunity. So, what are your thoughts on some of these combinations?
For now, in prostate, it's been very disappointing. Our combinations have not been as exciting as or as fruitful as we would have enjoyed liked. But based on a phase 2 with olaparib and abiraterone, we realized that patients that got the combination did better. But what was most striking and led to the design of the phase 3 that you're mentioning, the PROPEL study, is that we didn't need to harbor mutations to benefit, which was something very interesting, and was based on preclinical studies that showed that we actually create a BRCA type environment when we expose these patients to a hormonal therapy like abiraterone. And when we add the PARP inhibitor, the patients had improved progression-free survival regardless of their mutational status. So your point of some of the complexities of testing might not be as relevant if we show that the combination of hormonal therapy plus a PARP inhibitor are going to benefit patients regardless of their mutational status. So and there are multiple trials, like you say, with different hormonal therapies and different PARP inhibitors, all addressing this issue of a non-selected group, but obviously in the selected group of patients with mutations. And it'll be very interesting to see in the next few months how this pans out.
Yeah, I think it's really interesting too. I mean, there's this concept of enhancing, a BRCA-ness or PARPness so that in an all-comers population, it will be patients in addition to those who have homologous recombinant gene alterations, others who may benefit with combination. So I really appreciate that point. I guess one of the things that's always, intriguing is can you move these PARP inhibitors earlier? You mentioned that, into the MCSPC population. What do you think about that?
I think it makes perfect sense. We just need to be able to show this, and there are clinical trials addressing that patient population. that will go from MCSPS and CSPC to MCRPC in a relatively short amount of time. And so addressing these patients earlier on, so far, every time we've addressed earlier states of the disease, we've shown that we amplify the advantage of treatment. So, the trials are ongoing, and hopefully we'll be able to introduce these PARP inhibitors in patients earlier that are at the highest risk of actually suffering and dying of prostate cancer. Obviously, we're far from using this in patients who have localized disease, but I think the closest to MCRPC are the M hormone sensitive patients that we see, unfortunately, way too often. And that's a sad situation that we thought we had made this state of the disease disappear, but we're seeing patients every week with metastatic hormone sensitive prostate cancer.
Fred, can you comment on the frequently asked question, sequencing novel hormonal agents, especially in MCRPC, or even if someone's received a novel hormonal agent in combination in MCSPC, now they're MCRPC, what is your thought process about that and the concept of not applying novel mechanisms of action, especially if you have the option for a PARP inhibitor?
So that's a great question, Neal, and we've discussed this over beers several times over the last years, that this is unfortunately very attractive to go from one hormonal to another. Patients like it, physicians find it simple, but is it in the best interest of patients? Absolutely not. The majority of patients will not have any substantial response to going from one hormonal to another, regardless of when they got it. Whether they got it in the non-metastatic CRPC state, whether they got it in the MHSPC state, or whether they got it in the castration-resistant state. And you and I led a very important sub-analysis of the PROfound study, where the control arm was another hormonal therapy, and the treated arm was the olaparib, and then patients were able to get onto olaparib when they progressed. The response rate was dismal. In terms of time to progression-free survival, we're talking about 3.5 months. And there was no difference whether you went from Abi to Enza or Enza to Abi. No difference. There's a myth that going from one sequence, there's a huge advantage. There is no advantage. It's a question of days of difference. And in terms of survival, it was also quite dismal compared to patients who went straight to olaparib, even though there was crossover. So it really means that you're shortchanging patients going from one hormonal to another when they actually need a drug that targets their mutational deficiency of needing a PARP inhibitor. So, I think now we have multiple phase 3 studies that used a novel hormonal as a control arm that show that really these patients don't do well and progress quickly. And in our guidelines in Canada, we strongly recommend changing mechanism of action when you go from one drug to another and not staying in the hormonal realm.
Thank you, Fred. And also thank you for pioneering that analysis in PROfound. That was really largely on your shoulders, and I was happy to be part of it. So I guess in the final seconds, just take home for our colleagues regarding the role for testing, why to test, when to test, how you're teaching this at the University of Montreal, and how this has really been very important in the landscape of advanced prostate cancer.
Yeah, so how to test, I think patients that are at high risk, that present with high risk disease, should get at least germline testing. And like you say, this has become simple, routine, very cost effective. But if we limit ourselves to germline testing in the metastatic CRPC state, we might miss half of the patients that might benefit. And so if the germline is negative and you need to know, you need to go to somatic, whether it's blood-based or saliva or tissue-based. When to test? At the very least, anybody progressing on a novel hormonal therapy or an ARAT, such as Abi, Enza, APA, Daro, regardless of what state they're using it in, this is a good time to test, because this is our first opportunity to identify patients likely to benefit from a PARP inhibitor. And that's, I hope, an important take-home message. whatever state you started the novel hormonal in is irrelevant when they progress, these patients. So you don't need to wait until they're MCRPC and to start testing. If they're on a novel hormonal for MHSPC, non-metastatic CRPC, or MCRPC, and they're starting to progress, this is a really important time to start testing at the very least.
Yeah. Yeah. It's all about the testing. Thank you so much, Fred. That was fantastic. It's always a pleasure to see you and talk with you. And I look forward to visiting you in Montreal sometime soon and having some sort of, good beverage together in person. Thanks so much to the folks from eCancer for giving us the opportunity to share our thoughts and our experiences with you. This is always, great to see the advances we're making for our patients with advanced prostate cancer. So once again, thank you very much to eCancer and appreciate your time.